Okay, welcome. Well, we'll go ahead and get started for today. So, hi, Accelerator States. It was such a great treat to be all together in person, and we hope you were as energized by the discussion, presentations, and connections as we were. Today, we're happy to be together again, albeit virtually, to focus on building provider capacity to effectively deliver your housing-related supports and services. Before I preview the agenda, I want to acknowledge that the recent Supreme Court opinion on homelessness was disappointing and concerning news to many of us. It makes it even more important that the work we're here today to discuss solutions to the complex challenges related to housing instability and homelessness. To paraphrase Justice Sotomayor's dissent, we are hopeful that each and every one of us will come to see homelessness is a solvable problem when all parts of society together dedicate the time and resources to make the needed changes. Each accelerator team here is essential to ending homelessness, and we know you're inspiring other states to follow suit. Next slide. From the conference roundtables and TA coaches, we're realizing you're grappling with a wide range of issues related to provider capacity. Some of you are approaching this by striving to make the service and billing systems be more responsive to providers, the community-based organizations. It's a great approach that can begin by involving community-based organizations as partners in planning and implementing your capacity building initiatives, just like you've engaged people with lived experience. In that vein, we'll start the first part of our framing with a framer. Then we're thrilled California will tell you about CalAIM and how they've been building capacity and their lessons learned. Here in this main room, you'll have about 10 minutes for Q&A with them before the breakout starts. You'll get some perspectives on CBOs experiences with healthcare contracting from a recent survey. And as usual, about half of today is in the breakouts. Once we're back in the main room, we'll quickly close. Because it's very helpful, please remember to rename your Zoom square so it shows your name and state as in the past. We are recording all parts of the session for note-taking purposes. Also, please mute your mic unless you're speaking. So next slide. We're really excited today to have Marcella McGuire from the Corporation for Supportive Housing to get the ball rolling for us on capacity building. And with that, I'll hand it over to Marcella.
All right. Thank you, Ryan. Thank you to Richard Cho from HUD and all of our partners, all of our federal partners, our state partners, our TA partners, who are all here to make this important dialogue happen. We're here today to talk about building provider capacity. As Ryan said, my name is Marcella McGuire, and I have the privilege of leading CSH's Corporation for Supportive Housing's health and housing work nationwide. I've been in the field of health and housing at an integrated point my whole career, and never have I seen such exciting new possibilities within the Medicaid program as we're currently seeing with the 1115 waivers and with health-related social needs. I've been on the ground in DC and Philadelphia at the provider level, at the system level. I've worked across the country with agencies with CSH, and I can tell you that the agencies who offer Medicaid finance services and the community-based organizations who offer housing and homeless services, they may occupy the same geographies, they're seldom the same agencies, they don't know each other, they don't work together. All your states have goals as part of the accelerator around aligning, coordinating, and integrating your systems and creating equitable and accessible supportive services and supportive housing. We're here to learn from each other about effective strategies to help build that quality provider network to deliver those services. So next slide, please. The goals of aligning, coordinating, and integrating across systems and the questions your states are facing in these efforts impact system-level leaders like yourself, as well as direct service providers and the infrastructure that supports those direct service providers. On the provider side, goals around addressing social drivers of health of our community members is impacted by a lack of capacity, lack of service capacity, lack of agencies or trusted community partners, and who are able to perform required Medicaid functions, such as screening, assessment, billing, conducting quality assurance, and coordinating with other providers. There are many such agencies, both in health and housing. They're just kind of unicornish. There's just not enough of them. Agencies that are new to Medicaid may bring expertise in accessing housing-related resources and working with priority populations, such as those experiencing homelessness, but they'll have a steep learning curve to grow their service lines, such as enrolling as Medicaid providers, developing contracts with the appropriate entities, such as managed care or third-party administrators, and delivering quality services in a Medicaid-compliant manner. This is a tough hill, but it's not an impossible hill to climb, and I'm excited we'll hear from California today, who has tried to make that journey as easy as possible for valued community agencies. We all also know that the systems these CBOs have historically been responsive to are commonly not healthcare systems. CBO workflows, their internal administrative practices are oriented to their historical funding streams, such as HUD, public health, state or local funding sources, or philanthropy. As community-based organizations make this transition, coordinated messaging and guidance from the federal level, such as its accelerator, and systems coordination at the state and local level can support valuable activities, such as integration of data systems, combined agency workflows, technology, and infrastructure. Without this coordination, without that messaging, only the most risk-tolerant community organizations may capitalize on these important opportunities. If nobody says you can do it, they might not do it. The HSRN waivers capacity building funds will be crucial to these efforts. Systems integration efforts around all of these provider networks will be key to growing that network. And those efforts can also ease access and assure that your integrated housing and services that you're offered are delivered in our communities in an equitable, accessible, and in a quality manner. Next slide, please. For part of today's conversation, we want to talk about the concept and the potential of co-design between systems, between healthcare and community-based organizations, and how you include the people who use these services every day, what we at CSH commonly call, and many others do as well, people with lived expertise. Co-design requires an intentional and a collaborative approach to implementing new services and integrating existing programs. Co-design requires breaking out of our silos and sharing space with a group of diverse stakeholders, each of whom have much to learn and much to teach in the global effort. Using a co-design approach can help states under capacity needs from a variety of perspectives, develop the training and technical assistance and other support that is responsive to provider needs, and set up housing and services providers to deliver efficient, effective, high quality, and person-centered services. Next slide, please. In reviewing the good work of the states in today's audience and other states taking on these efforts, we see a framework with three unique and critical efforts. One, a needs assessment. Think of it as a landscape assessment to understand the many systems and existing agencies and community strengths you can leverage in your efforts. Two, a public capacity building plan to be driven by that needs assessment. That would include an array of supports, including training and technical assistance for agencies that are not used to either the housing or the funding, healthcare compliance requirements, and the funding that small grassroots agencies with limited cash flow will need to support this transition. Finally, a third piece of this framework is an evaluation to learn from these efforts and create a nimble, rapid quality improvement process that can create the provider network your community needs. Among all the states that are part of this learning track, we see many of these strategies I just talked about. From DC, with the integration of their state plan amendment, their Medicaid state plan amendment with their coordinated entry system. We see North Carolina's Healthy Opportunities pilots working across sectors, and we'll hear more detail about California. States have been most successful when they've taken the time to intentionally co-design system alignment, coordination, and integration efforts that operate across our sectors, across various networks, across our agencies, that's healthcare and CBOs, and when they include people with lived expertise at all stages of the co-design effort. Next slide, please. So California's recognized the complexity of these efforts, the need for a multi-pronged effort, and the investment needed. And Ryan's going to introduce our presenters from California here. So thank you all for letting me present this initial framing.
Thanks so much, Martella, for helping to set discussion for today and outlining the phases and steps for capacity building. Now let's welcome and thank our state team presenters, Glenn Zhang and Michael Weezar with the California Department of Healthcare Services, for telling us about their trifold approach to build system capacity and infrastructure to help deliver new programs statewide. Glenn and Michael will have about 18 to 20 minutes, leaving us with about 10 minutes for Q&A. So as they talk, please put your questions for them in the chat, and we'll then transition over to that for the QA portion. And with that, I'll hand it over to Glenn and Michael.
Thanks so much, Ryan. Good afternoon from California, everyone. My name is Michael Weezar, and I'm branch chief here at Department of Healthcare Services. And joining me is Glenn Zhang, who is our policy advisor for homelessness and housing at the Department of Healthcare Services. So we're really excited today to talk about CalAIM and some of the incentive programs that and waiver programs that we have. And we can go to the next slide that kind of just will preview for you, or one more, preview for you what we'll be covering on a broad level. So as I said, we'll be providing an overview of the Medi-Cal transformation in CalAIM, inclusive of two key programs, the Enhanced Care Management Community Supports program, as well as just really giving you some sort of background on whole person care, which really was the genesis of the work that was done, or that is now being done for Enhanced Care Management Community Supports, and then also covering the incentive programs, the Housing and Homeless Incentive Program, the Incentive Payment Program. Both of these programs are managed care plan focused, or managed care organization, if you're familiar, incentive programs here in California, and then also the Providing Access and Transforming Health initiative, which is one of our 1115 waiver initiatives. We can go to the next slide. So just kind of building on what I was talking about, we do have CalAIM programs that really provide members with housing services and care management, including the community supports, which is what we'll really focus on, as an enhanced care management, which is a benefit. We do have our CalAIM programs building capacity for providers, inclusive of housing services. So those being the incentive program, or the incentive program, incentive payment program, IPP, as well as the Providing Access and Transforming Health initiative. And then also that our efforts around building the housing capacity, which has been done largely through the Housing and Homeless Incentive Program, which Glenn will be covering in a later slide. So next slide, please. So as we talk about the Medi-Cal transformation and CalAIM, I just want to keep in mind, we'll be really talking about sort of CalAIM is a rather large initiative, and we'll be covering just enhanced care management and community supports to really kind of focus on how this relates to this audience. So we can go to the next slide. As I was saying, so CalAIM is really our long-term commitment to transform and strengthen Medi-Cal, offering Californians a more equitable, coordinated, and person-centered approach to maximizing their health and life trajectory. It also includes initiatives and broad reforms to various programs and systems that are part of our overall effort to strengthen Medi-Cal through our 5-year CalAIM waiver. We can go to the next slide. And for the community support, for the two benefits I was just sort of mentioning, enhanced care management being a true state plan benefit and community supports being an optional service that managed care plans organizations elect to cover, that really will be the focus of some of the services that, as I think, relate to this audience. So the community supports encompass 14 new services that are designed to really address members' health-related social needs. And as I said, they're optionally elected by managed care plans, but we do strongly encourage them to provide these services to our members to really live healthier lives, bend the cost curve, and improve health outcomes. Next slide, please. As just really kind of, we are early on in the journey. If we think, launching in January 1, 2022, that hasn't given us, a whole lot of time to really measure these programs. But a couple of the things that we've really identified early on with ECM and community supports is really just the Medi-Cal members typically have several complex health conditions. The members are enrolled in both Medi-Cal and Medicare, are more likely to report being in poor health than Californians only on Medicare. Our members with complex needs often are engaged in several different delivery systems, and then our individuals experiencing homelessness or unhoused have higher rates of diabetes, hypertension, HIV, and higher mortality. So we do know that addressing these social drivers of health is really key to advancing our health equity and helping to improve the healthcare for our members. Next slide, please. So early on, I said the whole person care was really sort of laid the foundation for CalAIM programs, and it really did. And whole person care, as authorized under our last Medi-Cal 2020 waiver, 1115 Medi-Cal 2020 waiver, really is included a variety of those sort of wrapped services and social supports that ultimately became the community supports. The Health Homes program was a benefit service program that was in select counties, and certainly really informed a lot of the groundwork for what became enhanced care management. So for those of you who may be familiar with California's health home programs, a lot of the core services that are offered under enhanced care management are offered today in enhanced care management. Next slide, please. So as and we can go one more to the community supports. So the community supports, as I was saying, are really those wrap services, and they're optionally elected by the plans, but they provide the medically appropriate and cost-effective alternative services or settings to institutional settings or to hospitalizations or SNF admissions, et cetera. And many of our plans are offering, they're increasing their elections. So in the beginning, they were offering a different combination of community supports, but as of January 1, 2024, many of the plans are offering the majority of community supports services, which is really exciting. And I just want to also highlight, because this is sometimes I think an important piece that many folks don't know, is that community supports can be offered together or alone with enhanced care management, just dependent on what the member needs. So you'll notice on the right side of these 14 community supports, they include a housing suite. They include sort of longer term services, or also some sobering center as remediation. So the services, as I said, if they're wraparound, they really help the members, or the goal is to really help the members stay successful in the communities that they reside in, and improve their health outcomes. So specifically, we can go to the next slide as we specifically talk a little bit more about for this particular audience of our 14 community supports. We have supports that are really focused on the long-term housing, the recovery-focused housing, as well as those members in nursing facility settings. So as you see, this is one of two slides, but the way that we were breaking up on this first one here is those for the long-term housing. Really, you might think of the housing trio or the housing suite. So those members who might need housing navigation or housing deposits, which are sort of funding to help support and securing housing as a one-time service, or to stay successfully in the house through housing tenancy and sustaining services, where they might need additional coaching and support. Recovery-focused housing includes those recuperative care or medical respite service in the short-term post-hospitalization housing, really focusing on members who no longer require hospitalization but do need that extra care and that support to heal from any sort of injury or illness, or provide short-term housing to those members who don't have a residence but do have a high medical or behavioral health need. So on the next slide is the third really sort of support for those members in nursing facilities. So the nursing facility transition or diversion to assisted living facilities for those who are sort of transferred from a nursing home to their own home or to an assisted living community to avoid a longer term stay, or that really nursing facility transition to a home where they're really able to safely be housed for members leaving a nursing facility and help coordinate that transition. So we can go to the next slide. Specifically for the community support providers, it really includes those delivering the service, those organizations that already have the experience in the community. So the one key goal of CalAIM was really to help focus the success and a lot of the work that has been done through prior waivers or already in the communities prior to CalAIM even reaching the 4A. So those who really have that critical experience as serving members and also in providing social services, including housing, or recuperative care, medically tailored meals, and so forth. But they do need to be contracted with managed care plans in order to be those community support providers and to serve the members. And really the providers will work with the managed care plans on negotiating their rates and working through that contracting piece. So the referrals for community support providers, it could be there's a sort of a no wrong door. It can be from ECM, other providers, or self referrals. And for the providers themselves, they really do have to have that lived experience and expertise. As I was saying, when we were designing CalAIM, it was really the focus was to leverage a lot of the folks that know their community members or know people in the community and have those strong ties, because they're the ones most best equipped to serve the members. And really just do need to have that capacity to provide culturally appropriate and timely in-person care management. This is really a really important piece of and a success of community supports. So as we progress to the next slide, we'll be now focusing more on how we're providing the support for the housing provider infrastructure, and Glenn Sang, our policy advisor for homelessness and housing, will be covering the first of the programs, which is the Housing and Homeless Incentive Program. So Glenn, I'll hand it over to you.
Thanks, Michael. Thanks for also laying the foundation. What Michael just presented is really the foundation of what we're trying to do in California for two major Medi-Cal transformation initiatives that we have. And what we wanted to do is highlight now how we are supporting implementing that through our managed care plans and providers. So next slide, please. Let's go ahead and skip to the next slide. So here you see 3 key initiatives that California implemented to really help build the infrastructure and capacity as we took on implementing our enhanced care management and community supports, which Michael highlighted earlier. Those 3 is the providing access and transforming health, the incentive payment program, and the housing and homelessness incentive program. I'll be focusing on that last one, housing and homelessness incentive program. I'm going to refer to it as HIP. That's what I'm used to calling it. So next slide, please. So the way California is structured is, we really push a lot of our services through our managed care organizations. We have 24 Medi-Cal managed care plans to serve 58 counties. And we also have like 44 COCs, for example. So just wanted to just lay that framework out in our approach to like these initiatives. So on one hand, we really had to help set our managed care plan partners up for success as they took on this work. So HIP, for example, was a 2-year initiative that began in January 2022 and just sunsetted in December 2023. What we did here was we took some dollars from our home and community-based spending plan initiative, which was authorized under the American Rescue Plan Act of 2021. And we turned it into an incentive program for our Medi-Cal managed care plans. So our plans, they had opportunities to, we laid out a framework that was metrics and performance-based set up for our plans. So one, go start talking to your community here, develop a landscape assessment, submit that plan, like what are the needs, where are the gaps that they fill, and then, they got payment for that. 2, all right, now that you know the gaps, what are the investments that you're going to make in your communities? And they got points for that. And then they also had 2 additional submissions, which were performance-based. Are they hitting on certain metrics like local connections with COCs? Are they attending COC meetings? Are they making connections to HMIS and entering into data sharing agreements? We also had a provision for investing in more street medicine, because one of the core components of CalAIM is better access for our members to receive services, especially those that are living unsheltered. So all these in HIP is very focused on homelessness and housing and setting our plans up for success, but also trying to really build those partnerships between our plans and homelessness and housing services providers through this. And, what better way to say than, well, as a plan, we have some funds and we would like to invest it. So let's collaborate community and figure out how best we can target these dollars and then hit on these metrics and develop a plan for that. So HIP in total was about a $1.3 billion initiative, which just sunsetted. So just really excited that, in the first 2 years of our CalAIM implementation, we had this going to just really support implementation, trying to build a runway for implementation. Next slide, please. So early on, we do track like what were successful investments, what was unsuccessful, some lessons learned, and longer term, like how are we sustaining HIP goals? So, really for Medi-Cal managed care plans, their task with these HIP dollars was really to build out the infrastructure and building capacity. We had 3 target areas for HIP dollars, or 3 buckets, I should say. The one was the partnerships and capacity to support referrals for services. 2, infrastructure to coordinate and meet member housing needs. And then 3, delivery of services and member engagement. So with like the ECM and the community supports, we want to see like members enrolled in ECM. We want to see members utilizing community supports. We want to see plans contracting with housing providers to deliver these community supports, and a lot of which there are plenty of CBOs in the community that were already doing this work. And then now through HIP dollars, let's do some seed funding, build those partnerships, Let's learn each other's languages, and then hopefully start receiving contracts to become like providers where they receive rates through Medi-Cal. So some successful investments, we did see a large amount of street medicine investments. So a lot more providers were popping up. They're known to the plans, for example, more landlord engagement, connections to HMIS. A lot of plans were sitting down with their COCs and mapping out their coordinated entry system. I'll try to not go over all of them in great detail, but there are some unsuccessful investments. Data sharing is always a challenge, especially during a program like HIP, where trying to enter into like data sharing agreements takes quite a bit of time. But HIP was a very intense short-term program, so it's like 2 years. So it's really hard to hit on certain benchmarks. But lessons learned, data utilization. I think we're moving on a few fronts with that as a state, but just at the local level, I think trying to enter into data sharing agreements between like a county that might have like 5 managed care plans or 4 or 3 or 2. So it's just a difficult dynamic to navigate in such a short period of time. Also realizing that trying to integrate housing and health, it does take time, it does take patience, it does take persistence in doing this. But we believe, and what I voice over quite a bit is, we're only halfway through year 3 of what we felt was a 5-year implementation. So we're halfway there and we are seeing some successes, but we are identifying some challenges as well. And I think the way that this is set up is, how do we sustain the momentum of HIP? We saw a lot of excitement among the community, among providers, plans, and partners. How do we sustain those activities, right? So such as street medicine. Street medicine's a different animal in terms of like how costs and the model and how services are provided. So how do we turn HIP, which is one-time funding, into more longer-term sustainable funding between plans and providers? And that's some of like the work that we've been doing to try to help bridge those gaps, because it is a different dynamic, a different switch. And then just continuing to like try to encourage and develop those data sharing, so plans have access to HMIS data, and likewise as well, where we have those agreements where we can see like a member's housing status, where we're sharing like, here's members enrolled in this plan and here's the services that are available, and then the plan can do their care coordination requirements. So all that is just stuff that we were trying to achieve through this HIP program, and we have seen overall success with this. Next slide, please. So I'll switch it back to Michael to talk a little bit about our IPP.
Thanks, Glenn. And thank you, everyone. And bear with me as I probably will skip over. It'll be a little bit quicker with some of this. We will have the slides, which is great, but also want to be mindful of being available for Q&A. So as we talk just a little bit now, the other incentive program, in addition to HIP, which both are managed care incentive programs. We can go to the next slide. IPP was really focused on broader aspects of CalAIM, not just enhanced care management, community supports, although many of the measures do focus around ECM and community supports. But really, it was a program that started in January 2022 through June 2024. So we're about to wrap with our last submission period. And really it was an involuntary incentive program for plans, just really looking to expand. So really kind of helping to lay more of the groundwork for them, giving them, if they meet measures, giving them dollars so that they can help build capacity, invest in the communities, build an infrastructure, and get more familiar with these particular populations. So a lot of the new investments are around care management capabilities and IT infrastructure and databases for new providers, because many of these providers were never really working in this space in this way with the managed care plan, especially as it relates to community supports, not so much with ECM. So there was a lot of investment that was need to be made, and that's really what IPP did. So we've seen a lot of great success with this program, and a lot of movement, and it has complemented the PATH program, which I'll talk a little bit more in a bit, but we can go to the next slide. And as I said, this next slide, please. For this particular program, I'll let folks read on screen, but really there were different domains. So around engagement, service delivery, quality, so quality measures, around infrastructure building, and then equity, access and support for different populations of focus. So we gave a lot of intentional thought around how we could best design this program to really kind of help focus managed care plans efforts to really support the providers and subsequently the members that they're serving, to really build that capacity infrastructure and create more equity and quality in the delivery of their services. So and just really quickly on the next slide, I'll just cover the timeline. As I said, this was started in Jan 2022. It's wrapping. Submission 5 is our last measurement period that we'll be receiving as of in September, and from our managed care plans, and then issuing final payment. So again, it is a managed care plan focused program. But managed care plans, once earned dollars, are doing a lot of this investment with their providers and the members that they serve. So next slide, please. This really kind of reinforces what I was talking about with data sharing, the investments that they're making, and the success that we've seen, expanding workforce investments. So like engaging with community health workers or promotores to engage enhanced care management community support providers, that's a newer benefit that the Department of Healthcare Services in California sort of got off the ground a couple of years ago. So a lot of great work, and ultimately I think our plans have achieved a lot of growth, and since 2022, and really sort of to really move the needle, I guess is what I would say, and with making investments towards supporting CalAIM initiatives. So not only community supports and enhanced care management, but also longer term services and other population health management activities. So for the next couple of slides, as we wrap the discussion on for the Providing Access and Transforming Health program, this unlike the prior slides or the prior programs that we were covering, is an 1115 waiver initiative that is multi-pronged, that provides grants, also technical assistance, and also sort of collaboratives or forums via collaborative planning and implementation initiative, sort of services and forums, a justice involved component. So it's a very, very ambitious but multi-pronged effort that we've been endeavoring on for the past couple of years. And we've had a lot of great success, and there's been a lot of great help and movement in getting and engaging folks that have never really engaged in this in the delivery system to engage. So we can go to the next slide. It's a rather large part. It's a $1.85 billion initiative, inclusive of state, federal, and DSHP funding, that really builds this capacity and infrastructure to implement and transform Medi-Cal as part of our broader Medi-Cal transformation. As I said, there's a collaborative planning and implementation initiative. There's this capacity and infrastructure transition, expansion, and development initiative, which is or cited, so they're like grants. There's a technical assistance marketplace initiative, and others. So a lot of great work. But the purpose of PATH has really just been to, as we go to the next slide, please, is really to kind of help fill gaps, like I was talking about, building on whole person care and health homes. But the organizations that can really play a key role in expanding care to our members, we've been able to really engage through PATH and through cited grants, or through these forums where providers, CBOs, managed care plans will join these regional forums to talk about how we can expand or improve services for ECM and community supports. We can go to the next slide as I need to wrap. I know the technical assistance marketplace, digging in a little bit more, it's just been something we launched a website. You can see here, it'll be inclusive in the slides, but there's 7 different domains where we're really any sort of recipient can engage with a variety of different vendors. There's with a variety of different scopes that really help to support through projects or hands-on projects to really get through contracting, through workforce training, etc. So it's a really, really exciting initiative that we're really excited to talk to that we launched. And I think, as I probably need to wrap. So Ryan, I'll hand it back to you, and we'll hopefully folks are able to peruse the slides. If you have questions, we'll save that for the Q&A. Thanks so much.
No, thank you both, Michael and Glenn. That was a really excellent presentation. So we have about 5 minutes for Q&A and state. And before we shift to breakouts, we want to help ground your discussions with some data and perspectives from leaders of community-based organization providers and community care hubs. For that, we're turning to Paul Cantrell with the Center of Excellence to Align Health and Social Care at US Aging. Paul, the floor is yours.
Great. Thank you, Ryan. Next slide, please. So good afternoon, and I'm pleased to share with you today an overview of CBO healthcare contracting efforts at US Aging and the Aging and Disability Business Institute. We performed a CBO healthcare contracting survey 5 times now since 2017, with the most recent survey being conducted in 2023. And I'm going to provide some highlights from that survey, which I think will actually dovetail really nicely with the last 2 presenters. I will provide links to the survey on the last slide, as well as some additional information. However, just to note, the 2023 survey that I'm going to talk about today, the data brief, toolkit, etc., are not yet final. So if you go to the link that's on the last slide, you won't find the 2023 survey for a couple more weeks, but it will be posted in a couple of weeks there. So let's get started. Next slide, please. So for purposes of this survey, we were interested in contracts in which CBOs or networks of CBOs receive or will receive payment from a healthcare entity. This question, and all of the questions I'm going to talk about today, were asked of respondents that across the CBO world. So some were area agencies on aging, CILs, and other CBOs that are out there. This particular question was related to overall contracting status during these years. The important data point on this slide is that CBOs, especially the growing number of aging and disability networks of CBOs known as community care hubs, have contracting experience. And while many of the contracts remain small, the breadth and volume, as well as the number of CBOs involved in contracting, is growing. Additionally, as you can see in the top right today on this slide, those contracts are delivering quality work as most contracts are being renewed. Next slide, please. This question was asked, and the remaining questions I'm going to show you were asked only of respondents with contracts. So most common services provided through contracts. And of note for the discussion today, you see affordable housing highlighted in the second bar related to assessments and screenings. I also want to note that while it's not on this slide, 14% of our respondents offer a housing assistance program under contracts with healthcare organizations. Next slide, please. This question was specific to high risk, high need groups and those that are targeted in contracts. And again, this question was only asked of respondents who do have contracts. It focused on the question specifically, which of the following populations are eligible for services through your contracts with healthcare entities? As you can see, the last row notes that homeless individuals and those that are at risk of becoming homeless represent 16% of those eligible for services under these healthcare contracts. There is some noise in the data that we've not yet teased out between the 14% I mentioned on the previous slide and the 16% noted here. But the important point is that housing issues are an important part of these contracting efforts, and the recognition of the need is only growing. Next slide, please. Now, what type of partners are CBOs contracting with? As you can see on this slide, it's a wide range of types of healthcare organizations, from Medicaid, which we just heard California talking about, to directly with hospitals and health systems. The VA is doing a lot of contracting work, as well as large commercial or employer-sponsored plans and Medicare Advantage plans, and D-SNP types of plans with Medicare and Medicaid. The most common, next slide, please. The most common contracting challenges you see here on this slide In the left column, there remains a lack of broad and deep awareness among healthcare organizations, and I want to point that out. Next slide, please. The other initiatives that started organically, or another initiative that started organically and is now being encouraged by state and federal policymakers, as well as healthcare organizations and leaders across the country, is something called community care hubs. You may also know of them as umbrella or backbone organizations. It is a response that addresses the complexity and anxiety healthcare organizations express when seeking to find CBOs that can deliver predictable and consistent results. And it responds also to one of the questions of the last presenters, is how do CBOs do this work? Community care hubs allow them to aggregate administrative responsibilities across a lot of CBOs, and that helps to spread the cost and share services and expertise. Next slide, please. This just gives you a contracting map from what we learned. And then last slide, these are the resource links that I talked about, and they'll be in the slide deck when that comes out. And I want to thank you for the opportunity to share our survey results with you today.
Thanks so much, Paul, for the concise presentation.